I don't know if they were just like, if it was just broken or something, but you can see it bubbling. It doesn't immediately deflate, does it? Okay. Well, tonight we're looking at respiratory. One of my favorite chapters. I was thinking initially antibiotics. You might treat something down here differently than you would up here via whatever antibiotic you chose, maybe. So say they were really significant. Look at this slide right here and tell me, what do you think might be impaired if it's a lower respiratory tract infection? Gas exchange, right? Probably up here too, but down here it's where the filter is, and the filter's clogged if it's congestion. Okay, up here we can swallow mucus, we can get rid of it out of the nose and oral cavities, but down there it's just wet, you know? So right now we got all of them. Upper includes nose, mouth, throat. I think pharynx would be the cutoff point. Then we got larynx, trachea, bronchi is plural, bronchioles, alveoli. Oh, it's one eye. There's the lower. Okay. You can see a good diagram of them there. I'm going to rely more on the board tonight than I am mainly like making sure you get information off slides. These are more of a guide for you tonight in this chapter. So when you talk about ventilation or breathing, there's two different types going on. There's the actual moving of air in and out, like we witnessed here, okay, the ventilation part, but then on a cellular level, there's a gas exchange happening there. So understand the difference between those two, right? Just like you can have cell respiration, or you can just straight up have respiration, okay? Yeah, great, conducting zone. Yeah, they cook them individually, to order.
Still out there?
You now get to enjoy your prize though. Okay, pulmonary ventilation, yada yada yada. That's the number one function of this system is gas exchange. Other than, what else can you think of? What do we use our respiratory system for? Other than breathing? How about speaking? Right? Yeah. Singing? All right, good. Everybody sort of maybe remembers that pH of your blood is dependent on some gas levels in there and acidic or alkaline conditions. Oh yeah, we smell too. I guess it's involved in that. Okay, any questions so far? You guys are gonna have to talk to me. So in talking about the upper airway, think about your nose, all right? First of all, you wanna understand that there is a oral cavity, a pharyngeal cavity, and a laryngeal cavity, top, middle, bottom, right? The oral pharynx is the space between the oral cavity and the pharyngeal cavity. And it's just like the body cavities. You can have dorsal cavity, spinal. You want to get that straight. Okay? Up here, we've got these ridges in our sinuses called conch, or conchae, I guess. Why do you think they're there? What does it say? It says where they're at, right? This is what the ridge is right now. If I take this line and I straighten it out, it's actually a lot longer here, or it appears longer here than here. It's the same line, right? So it just increases surface area for air to pass over, like ridges, you know? Because that air that's coming in to our lower respiratory is being warmed, it's being filtered, it's being moisturized, so it helps in that as it goes down. I don't think I'm really interested in, let's talk about the nares, the nostrils. If you watch in the future, you know it's an oxygen-starved patient. I think I've told you this before, you'll see nasal flaring. That's a sign of oxygen starvation. It's amazing that whatever that little movement does can actually help, but it's sort of how we extend our smellers. I was going to say one more thing, but I forgot what it was. Oh, oxygen starvation. You'll see like everything's kind of barrel-chested. Put those two together when you're on the floor. Right? Have flags go off for yourself as a nurse. This guy looks oxygen hungry. I just told you all that. We kind of talked about speech a minute ago, but it allows us to resonate the spaces in our skull as well. There's a good detailed picture of it. So that's what I think of when I think of pharyngeal. I think about a chamber that's getting my air ready. And then I think about a bottom entry for food and water. And then this third door is to the back or to the front, right? Trachea or esophagus. This is where you want to focus on anatomy for this chapter, okay? You want to know what the epiglottis is. Vocal cords, what are they made of? What kind of tissue are they? What's some of the problems you can have with them? You can get polyps on them if you're a singer, right? If you're a smoker, that's pretty bad for them. People who age have problems swallowing. Those muscles that are very finely controlled, it's a higher functioning status. They'll kind of go first as people decline in old age or with the disease. So they're often doing speech therapy. And you're looking for signs and symptoms of coughing, right, as they eat. People who are AIDS or been in the field, they know about that stuff. This is all great, but look at these frontal sinuses up here. Do you know you have those, that big a space in your skull? They can be tender if you have a sinus infection. Infraorbital there, a few others. They just discovered in 2020 or 2021 new salivary glands in the back here, or new like tonsils, adenoids. It's a new one of those things during COVID, swabbing back there. Actually, it was really related to how COVID got in through our nasal passage and went into our brain and our system that way, through the nose. I've already explained this to you, okay? How we talk about these sections, some of the stuff you should be interested in. I still have no idea what the uvula is for, the little dangly thing in the back. I'll figure that out one day. Okay, let's talk about the voice box in a little bit of detail. The trachea itself has C-ring type cartilages in it, and they're stacked on top of each other, right? Where do you think this is, anterior or posterior, if you're looking down someone's neck? If you're looking from the sagittal view, is this anterior or posterior? Two tubes run down beside each other, right? One's going as it goes down to your tummy. So this would be posterior because the esophagus is right there, and then this would be anterior of the trachea. Get what I'm saying? I mean, you got textbook that look at diagrams. This is all right there. I don't know if it's in detail here. Yeah. So this is from the posterior view. There's our tongue, trap door, and those openings in the C-ring cartilage. There is cricoid cartilage right here. Everybody can feel the cricoid notch. Try it. You might want to tilt your chin back just a little bit, but there's stuff, but there's a definite notch if you just feel a little bit right there. It's called the cricoid notch. That's where you're gonna like stick in a pocket knife and put a straw in if you're in Old Yeller, you know, like emergency. That's the place you would look for. In surgery, if there's like a spasm in here, because maybe it got activated some way, saliva, fluid, a tooth went down the wrong pipe, it might spasm and not open, then they're gonna die from choking to death. They're not gonna get oxygen. Well, we got this like, looks like a pacifier with a sharp needle on it, and you're supposed to feel right there and go, bloop. And then you give them a medicine that will paralyze the respiratory muscles and call an ambulance, send them on to the hospital, and let them get it out. So that cartilage is important. It's an important landmark. Roger that? But it's the thyroid cartilage that gives the Adam's apple, okay? Do you need some space there?
Right on, okay.
I'm not really worried about these whatever these are down here. There's like 2 sets of vocal cords. Some say there's like a tribe of monks that can activate the lower one, and they do this weird singing. That's not just from a movie. I'm not gonna get you on muscles or anything for this chapter, so you can count those as gone. Let's talk about the epiglottis itself. Here it is. Okay, so this is my airway. Fortunately, the trachea is not in there, or the esophagus, but it's just gonna go over that hole when it's closed. Everybody understands about the vocal cords. It's high pitched, they're thin and close together. The wire part, you get lower pitches. I'll show you a video of a laryngoscopy here in a minute. It's pretty wild looking.
After the nose is numbed and decongested with a nasal spray, a flexible endoscope can be threaded through the nose and into the throat in order to visualize the voice box. Both adults as well as kids can easily tolerate this procedure without sedation. Let's take a closer look on the inside. Here, the scope is being passed through the nose. After reaching the very back of the nose, the scope is then bent down in order to visualize the throat. With further advancement, one can see the base of the tongue as well as the epiglottis. In this position, the vocal cords can be seen coming together to create sound. When breathing, the vocal cords move apart in the shape of a V, allowing air to pass between the vocal cords into the windpipe and down into the lungs. The pitch of a person's voice can be altered by reducing the throat diameter as well as decreasing the height. This alteration is analogous to an organ pipe where the smaller diameter and shorter pipes create a higher pitched sound compared to an organ pipe that is larger. As shown here, the vocal cords themselves can also adjust their thickness and tension to adjust pitch. Just like a violin string, the thinner and tighter the string, the higher the pitch. The thicker and looser the string, the lower the pitch.
That's all good stuff we've talked about. We do need to talk about the cells on the way down there. First of all, it's a mucous membrane all the way down, right? Any lining of tissue that covers a cavity or opening of the body to the outside is a mucous membrane, allows for permeation or absorption and excretion, right? So right now we're talking about absorbing and excreting gases. Epithelial tissue can be squamous and all that. The ones that are classic for the trachea are, is it columnar or cuboidal? Columnar, I believe. Ciliated ciliated columnar epithelial. Hint, hint, hint. It's a good one. So ciliated are those hairs. What do those hairs do? Like, they just sit there? Are they moving? Yeah, they're beating back and forth. And they're moving the stuff that this goblet cell here is excreting, called mucus. This mucus is being great for, it's great for catching things that are in there not supposed to be, like dust, bacteria, and then they just move it on out. Okay? That's why, well, it's not just a side thought. We need to talk about that a little bit. Smoking will paralyze these temporarily. It'll come back after a couple minutes. So if you think about that, you think about constant inflammation, nothing being moved out, or it's at a disadvantage, and plus all the stuff that smoking does to your immune system, you can see why somebody be set up for failure after a long period, like chronic smoking, right? Like exposure to that stuff. And I'm a former smoker myself, so I'm not dogging anybody. But think about cystic fibrosis and mucus production, those types of things too. So lining of the trachea, columnar cells, goblet cells, mucus, cilia. We'll learn in the digestive chapter here in a week or two. They're sort of similar, but their extensions are called villi, and they are just extensions of the plasma membrane. These are things on the outside of the cell. That's an important distinction to make. This increases absorption for food passing through our gut. Good? Okay, so let's talk about below the trachea after it branches, the bronchioles or the bronchi. You can look at this real life model up here. The first thing I can see is one is shorter than the other. We're talking about where it branches and goes before it gets to the lungs. That's a better picture to be on right now. You can see good diagram here. And there's smooth muscle in there that will allow constriction or widening of the opening for either increase or decrease airflow. If it's a smaller type of bronchus or bronchi, then it's called a bronchiole, just like an arteriole and a venuole. Everybody good on this one? I'll spruce these up and put them back out in Moodle for you. The alveoli are the microscopic sacs at those great clusters at the end of the terminal part of this tract. Here's what you need to know about alveoli, or alveolus, I think is a plural, or a single. Alveoli is multiple. Yes, they are microscopic air sacs. And they are all going to be typically one cell thick. If I were to zoom in on that, it would be epithelial squamous cells. Here's its nucleus. I mean, I could pull out the slides or show you a picture on the internet. So this is a sac on a slide. It's like a transverse section. Very thin cells and single layer thick. This aids in diffusion of O2 in and CO2 out freely. COPD, chronic obstructive pulmonary disorder, and some others that smarter people know about, these sacs will not be as elastic as they should. They kind of get scarred over, and then that is going to compromise gas exchange and make people, sick, oxygen poor. If you took your lungs and stretched them out over a surface area flat, they would cover a tennis court. So that tells you like the kind of diffusion and the amount of stuff going in and out of you, and like how efficient and wonderful this invention is. I'm sure this is very important for like giving certain types of drugs is going to help people get fluid off of their lungs, or maybe treating certain types of bacteria, but that's for the medical professionals, and it will come if you get to that point. So I'm not going to worry about the minutia of the respiratory membrane, just the sacs, single layer, epithelial, stuff like that. This is a better picture to aid in it. I like this picture. I'm counting on you guys to go back and look at this, okay? Okay, good. We can get out of the respiratory tract and go look at some macro stuff here in a second. Let's take a break. So, thinking outside now, what aids us in breathing? I looked at the microscopic aspect a little bit. I'm going to pass this around. Everybody take a few minutes and look at it. Okay? You do have intrinsic and extrinsic intercostal muscles that aid in expiration and inhalation. So there's two sets of muscles pulling and pushing there. There's one other big muscle I'm thinking of right now that aids in breathing. Yes, very good. That large flat muscle that separates these two cavities. Sometimes it spasms or get hiccups. Where's my eraser? And that works by expanding the chest cavity and kind of pushing everything down, because your chest is a negative pressure area. The atmosphere is pushing. You should really take to heart and just put in your knowledge bank that there are two lobes on the left, 2 lobes on the left lung, 3 lobes on the right lung. That's in that good picture right there in your homework too, isn't it? So when I'm assessing a patient and I'm like, well, let's listen to lung sounds. I'm listening up here for wheezing, and that's usually the stethoscope will be right up here because I'm listening for those bronchioles. I'm assessing before and after a nebulizer treatment. I'm charting that. If I'm assessing down in here, they got a cough, I'm going to really check the lowest spot that fluid can accumulate in the lowest lobe of the right lung. But there's no lung over here to listen to on that side. So, you don't want to look silly. Upper or lower lungs, mainly on the back and the sides of the bodies where you place your stethoscope. I would be happy to break those out, but I don't know if I wanted to add one more thing in tonight. This is how we can like cut out part of a lung and people still live, these segments and lobes. Right lung, I'm doubting myself. Is it the right lung that has 3 lobes? Yes.
So why is it that the right one's bigger than the left? Because of the heart being on the left side?
That's what I think of. It doesn't make sense because the big old liver's over here.
Yeah.
But there's got to be a space underneath where your stomach can connect to your small intestine without like something pushing on it constantly, In my opinion. I mean, we're talking about why did God make us that way? Hey, you guys already are experts on this stuff. But, you won't see questions about them again. Okay, I'm going to let you just take notes of these cavities. I'm going to let you teach yourself on those. And the linings of them, all right? That's sort of back to chapter 1 stuff. Pleurisy is another disease you might want to think about looking at. I think it's in the back of your chapter. Already talked about that. Remember, this means in between ribs, intercostal. Abdominal muscles are important too. I should have mentioned those. One reason I'm always keeping a close eye on Hudson is because, we'll just be sitting here watching Hotel Transylvania 3 for the 6th time that day, okay? And I've been playing, I've been running, but he's like, ugh, ugh, ugh. He has a pass in his mouth, that don't help. But he's also got a lot of boogers and stuff. And I'm like, this kid he's like trying to get oxygen in him. And there's a difference between it and when he's actually sick. And that was one of the questions I asked the nurse practitioner. I think he's just kind of being a cross between a baby still that's belly breathing. And those muscles are not just like holding him and helping him do that. So he's just like, this is hard to breathe right now. It's just the way I'm built type stuff. I'm also looking at his skin color. You know, what happens to people when they are short on oxygen? What color do they turn? Don't say blue.
Gray.
What's the medical term?
Cyanosis.
Very good. Yes. Cyanotic. I'm looking for blue lips. Looking for nasal flaring. Yeah. You all saw the bell thing? Did you put your finger on top and then try to pull it? That's what happens when you got a ham sandwich in there. I should say that a respiration, when you're counting them for people, you got pulse, blood pressure, all these vital signs. One respiration equals one inhalation and one exhalation or exhale. So when you're counting respirations, you watch your chest go. 1, 2. Okay, it's like army push-ups. You have to go up and down to get the count, not just up. What's normal respirations for an adult?
16 through 20.
Very good. You sure it's not 12 through 20?
Yeah, it is. 12 to 20.
12 to 20 respirations per minute. That's an adult. You got an idea for a kid?
It's higher, isn't it?
I'd say 22 to 30 something. I need to go look at the textbook, but it's always faster. Kids always do things faster, pulse, than adults.
It's higher than 30.
Yeah, I'm sure it is.
Do kids' blood pressure stay higher than ours too?
I don't know. That's a good question. I don't know. Yeah, it's hard for me to think about because their pipes are smaller than ours. I don't know if you can compare them. You'd have to like have a way to normalize those two things before you did a null hypothesis. Before we go to that, total. There's all kinds of different ways to measure how people are breathing correctly. One is the volume, you know. If somebody is only getting that much air because either these are sclerosed or scarred over or for whatever reason versus what they really could get in there, you're not just going to have them blow into a balloon and measure the balloon. You got to like have them do a long exhale and get the force that's coming out. Is it enough to actually ventilate? Are they getting enough volume of air? There's the things in the hospital that help you practice this after surgery. I forget what they're called. Inspirometer. It's a lot harder to breathe in than out. I thought I had some students bring me some from the hospital, but I can't find them. They can put a bag on you and the computer hooked up to it and measure this for certain reasons. Think about ER type patients, or if you work in a cardiopulmonology office. Here's a good sentence I will highlight later. Emphysema have enlarged villi because walls have degenerated, giving less surface area for gas exchange. So let's make sure we all learn what vital capacities means. Now I'll just go with that term this semester and make sure I understand what vital capacity means, okay? Just taking some oxygen. I'm worried about you measuring or knowing the definition of that stuff. This is cool. I've got a book in there I got just because it was free, and it's physiology of extreme sports or something. So it talks about the scuba divers and the nitrogen and the gases they have to have when they go deep ocean diving for extended periods. People on Mount Everest, the oxygen content and the atmospheric content. Our atmosphere is mostly nitrogen, which we don't use. This is a good term, surfactant. It's what helps develop lungs when you're in utero. It's about all I know about it. I know you can test for it. I know there's issues with it that are well documented. People may have kids in here, but have you ever like been on, I just remember my clinical on OBGYN rotation was in Norton Hospital in Louisville. Like they do more babies than anybody in Kentucky. And since they didn't want just a guy standing in front of the female giving birth, like just kind of gawking at the whole situation, this is a great term you should know for sure. A pneumothorax. This will make you sound smart if you're able to say it in a sentence in a normal conversation. This means collapsed lung. This is something you definitely want to come back and look at because it's very critical to a collapsed lung. Everybody, you're going to have to recall from back in grade school or something, like we have an atmosphere. And so if this is the ozone, this is the world, this is a very crude demonstration of it. It's pushing air into our lungs, and that aids us as we go. There's also an atmosphere pushing it in. It's at a level of 1 atmosphere, or 760 something bar that they said on the previous slide, okay? If this is you in your chest cavity, and there's a hole, like from a bullet wound or something, the atmosphere is now rushing into your thoracic cavity and pushing down your lungs. Before that, it was a negative pressure environment. So your lungs are naturally pulled out towards the walls because there's no atmosphere in there pushing them down. Does that make sense? You know how if you go into space, you just kind of explode because there's nothing holding you together? Yeah. Or if you go to space without a suit. You guys follow me? Pulmonary ventilation, or respiration regulation. Where does that happen? In the brainstem. So if I ask you, is breathing involuntary reaction? It's like, well, it depends. Are you thinking about it or are you not? Who's taking their med-term exams? I posted the quizzes. I got 2 more on there. I mean, they're due at the end of the course, so you got time. You're not like, but you should make sure you see that when you come to H's. There's hypoxemia. There's hypoxia. And hypoxemia. So you want to know the difference between those two. I mean, it's like 1 point, but this is another part I want to wrap up. 2 more important terms, hypercapnia and hypocapnia. Somebody remind me while you're writing that down, the term for respirations above 20 for an adult. It's your medical terminology. No, don't Google it, don't cheat. Do you remember if pulse, like if your pulse is too high?
Too high, it was tachypnea.
Okay, you got half of the word we're looking for. The tachypnea. Good. And then it's bradypnea. Too slow. So remember the suffix here. It's pneumo, to breathe. I think the Greek word in the Bible means that's the same word. They use the word pneumo for spirit. God breathed his spirit into Adam. And I'm seeing a little bit of that right here. That's why I call that out. Droning on or what? You need a break? I'm just trying to get through here. I'm almost at the end. Threshold apnea. There's another good term. The A means without. Another one I really like is orthopnea and dyspnea. Difficulty breathing. better breathing in another position, like ortho.
Like standing, or sitting, or
Yeah,
laying.
like sitting on the, some patients that are experiencing whatever problems with lungs, they'll, if they sit on the edge of the bed on a bedside table like this, it's way better for them. They're orthotically positioned to breathe better. People who have, I remember learning this in nursing school, who are low on oxygen. First of all, you walk in a room and you're starting to suspect something. People who are low on O2 are acting very squirrely. They start ripping their clothes off or hallucinating. I'm going to pause for a break after this, okay? And so you should be like keying into this stuff. They're like, is my lunch ready yet? You know, doing crazy stuff. And so the people who are going to be at risk of that are people with fluid in their lungs, whatever reasons they're sick, it's affecting their respiratory. So the best position for a lot of those folks is head of bed at 45 degrees. You guys remember that from sRNA stuff? 45 degrees or greater. Is that right, David? Fowler's position. There you go. Man, cha-ching. That's
That's for anyone that's on oxygen, right? I always have their head elevated.
anybody that needs to breathe better, really. But O2, no, not necessarily because they can go to sleep. G-tube patients, yes. So keeping G-tube, constant G-tube feed patients at this or head of bed at greater than 45, 30 minutes after meals keeps the fluid from coming back up and going down the trachea. People who are on oxygen, they can sleep on top of their head if they want, but if they feel better like this, then great. There's something about fluid on your lungs and edema and congestive heart failure that it's not flat, it's not up, but it's right like this that is a sweet spot, 45 degrees or greater. So that should be your first thing. You walk in the room and you're like, what's going on? You get that head of bed up and calm them down. We talked about this a little bit, emotions. Don't forget about these other respiratory actions too. Sneezing, coughing, things meant to help expel stuff from your respiratory tract. Okay, let's take a break there. Let's take 10 or 15, right? If I keep y'all till 7, will that be fair enough? Or
I got a
some,
question.
yeah.
So, like in lab work, like I've noticed, like they check your CO2. I know that's supposed to be checking the oxygen levels in your blood, right?
It's checking the marker that they need to know for the chemistry of your blood. Oxygen is simply a molecule, or a 2-atom molecule that will accept an electron when the cell is doing its thing to make cell energy. It's just an electron acceptor. That's all it is. Carbon dioxide is really what drives the physiology behind respirations. Does that answer the question?
So what happens if it's too low or too high?
Well, that's what I shied away from talking about a minute ago. Back to the carbonic acid and the buffer and all that stuff. Our blood pH, I'm just going off my own memory here. This is off record. That's normal blood pH. If I hold my breath, CO2 increases. And CO2 dissolved into water, which is what my blood mostly is, produces carbonic acid. Does everybody see how I got there? And if there's more acid in my blood, that means pH is going down to 1, toward 1, instead of up here 14. So what was your question again?
What happens if it's too high or too low?
All right, so if CO2 is too high, my blood becomes more acidic. I'm going to have increased respirations to blow CO2 off. Okay, this equals increased respirations. I would encourage someone to go check my math on it, or logic. All right, I know if a diabetic, you guys can go on break if you want. If a diabetic becomes too high in sugar to where ketones are forming, yeah, that's not really related. I think that answers the question. Google that and make sure I'm right.
What time do you want us back?
15 after. Everything's rolling over here. This is a good slide. Talking about the stuff we were talking about earlier. It lines it out for you right there. That jives with what I said over there on the board. Increased pH means lower on the scale, 1, which also correlates with increased CO2, more carbonic acid. So you got your receptors that are somewhere around these locations, the chemoreceptors, remember? A few others in there. These are some good terms to make sure you're looking at. Bronchitis, inflammation of the bronchioles. You can have bronchitis for numerous reasons, but you've heard some people say in your lifetime they got bronchitis. I have bronchitis, right? That's a very common thing.
Question about that. So, like, whenever, like, you know, how you get, like, seriously sick and you're diagnosed with bronchitis, that's always acute bronchitis, right? Because, like, bronchitis would just be a chronic in some people, right? And that would just be bronchitis, but, like, whenever you're just temporarily sick, you're just a case of acute bronchitis.
Yeah, have you heard it referred to as acute? Just out of curiosity?
Yeah.
I think
So
it's
they asked me, like, what's the difference?
sort of like redundant. Maybe. I'm not a doctor. There might be an insurance mark or two that treats it differently than regular bronchitis. I say it's really the case is what's going on. I'll bet somebody a milkshake on that. Emphysema is long-term, chronic for sure. And, you know, to answer your question, I should have said, well, let's look at the root of bronchitis, itis, inflammation. Itis, you got the itis. Dermatitis, stuff like that. I'd say this this is fire victims. You know, it's the inhalation of smoke that kills people before the flames do in fires. And just their lungs being kind of damaged from the intense heat and the stuff that's in the air. Doesn't allow for gas exchange. Cystic fibrosis, genetic disorder. This is congenital, meaning you're born with it. These patients I've treated in the long-term care facility. They're young, but they have nowhere else to go, and so they're in the long-term care nursing home. Or, you know, they've got better care somewhere else, but a lot of people who don't have any other people taking care of them, they just end up in the nursing home, even though they're young people. This guy that we were treating had a wound on his bottom that I could put both my hands into when he was admitted. 2 years later, we finally got it healed up. But he had cystic fibrosis, and he was paralyzed from a gunshot wound. So like just triple threat. He had this vest we would put on that would like so many times a day, 4 times a day, and he was on mini-nip treatments continuously. And that's because he couldn't get up and move himself. So he had to have something to physically vibrate him and get that mucus moving.
So I kept him from building pneumonia?
Right. And there's a drug. I mean, they figured this out and come out with a drug that increased people's lifespans in like the late 80s or early 90s, maybe sometime around there, that just dramatically increased like 20, 30 years people are living with this, when before they would be dead at like 15 or teenager usually. And the drug is very common, but it's super expensive, like insulin. It's crazy how it works. But it just allows that mucus to be moved through more, and it's a pretty simple but elegant solution to that disease. Here we got fibrotic scarring of the pulmonary tissue. That really happens when things like asbestos or microscopic particulates get trapped in the tissue. They can't come out, so your body just kind of scars and walls over it. And so if I look at a chest x-ray of you, there'll be the little white spots where no x-rays are getting through. They'll be opaque, and they'll be there. And it'll like, lungs should be black and clear on an x-ray, but when it's milky white, opaque, it's either fluid or scar tissue. Everybody knows about lung CA. Asthma we've talked about. Pneumothorax isn't up there, but that's another disorder. Clot in the lungs. Okay, I've heard about two different, you told me about that. And another student just had the same thing happen, young female. And I'm like, I wonder, you know, if it's condition or something that's just relevant to females and their age and the clotting stuff. She's okay. Say it again?
So were they all on birth control? No.
I don't know, I didn't go that far into my investigation.
I had small, but I had so many blood clots in the vessels and in the two main vessels arteries. But they were small, but they had so many they couldn't count them. They just told me I had extensive blood clots in my lungs, and they called them unprovoked. And they didn't know what caused them.
That's crazy, because they're having like normally like in females at a young age if they're having like.
But they asked me all kinds of questions. They were like, were you on birth control? No. You're a smoker? No. Have you had any injuries? No.
I want to find this image of a real blood clot from the lungs.
That ever since they had COVID,
Here it is.
They can't get rid of DVTs.
That was taken out of a lung.
I can show you my x-ray. I can pull it up. It was pretty scary. My doctor came in. He said the only thing that probably helped save me was,
Look at that one. Go ahead, Winston.
no, I had, I didn't know I had the blood clots, but I had been experiencing chest pains for like a really long time. So I like popped aspirin like it was candy, and aspirin is also a blood thinner. It's probably the only thing that really helped you with as many clots.
Hopefully that's connected some stuff for you. You know, people who's anemic are going to feel tired and short of air, but all the oxygen in the world ain't going to help them, because it's a matter of transporting it to their cells. That's the problem. This one we are going to revisit. This is part of what I'm going to trim in with the slides. This one has been solved just about a year ago. A doctor who had a baby die when she was a young woman, 20 years later, solved the problem of what SIDS is. For a while we thought it was the mattress or the way the baby was sleeping, belly versus back, right? When you're a parent, you'll think about this stuff too, but it was scary. It still is scary. It's an enzyme they're born with that they're deficient in. And the enzyme leads to, you know, like if you pass out, you just kind of spontaneously start breathing again. That response is immature, and the enzymes are not there to help it like overcome it before it's too late. She figured that out. I'll have to go dig that up for myself. We can give drugs to help with this, especially in anesthesia or in emergencies like the laryngospasm. Yeah.
I know it's something that really scared me with mine. SIDS.
Mm-hmm.
I was, paranoid.
They say don't put any stuffed toys in the crib. No extra blankets. No pillows. Like nothing to like just challenge that very immature response of like taking care of your own breathing on your own autonomically until a little bit more stable. Until they can move their head. That's it. They can't even move their head away from something blocking their air. So, we could talk about these at Med Micro. I'm really wanting to hit this chapter at Med Micro before we part ways. Strep throat. Notice how these are upper versus lower. Okay. Tuberculosis is not on here, but it should be.
You said tuberculosis, it was on there.
Where? See, whooping cough, diphtheria. Oh, TB. Histoplasmosis is not on here, but it should be. No, I'm just joking. All right. I got a couple more things to give you here.